Hello to everyone. We are the first ISICEM chat. I'm here with Professor Jean-Louis Vincent, and of course, it's the first after ISICEM. So the first question for Professor Vincent, who is the chair of the meeting, is what's your first feeling about the meeting?
Well, Fabio, we have done it together, and so we can address the question together, but it was a real challenge to organize this meeting, and we are proud to say that it was a big success. All the people who were there were really very happy, very enthusiastic, very supportive, and they congratulated us for having maintained the plan to organize this meeting as a face-to-face meeting, not a hybrid meeting, face-to-face meeting. Now, still, there are many people who can watch the video thereafter, and so there is a total of 4,800 people who basically have registered and can have access to all the conferences. Whether they were present or not doesn't really matter. It's almost 5,000 people who could look at the conferences.
I agree with you. I think that there's been a big stress for organizing the whole meeting, to adjust the program, and to be sure, of course, the people could attend with all the restriction with the COVID for travels. But I also had many very good feedback for people. And basically, people want to not only have lectures, but also interact with the speakers, interact with the faculty, create network, discussing about studies. And of course, the best way to do it is meet, when it is possible, face-to-face. So these are, again, a very positive feedback. And we, of course, all hope that in the future, other meetings will follow and we will progressively go towards partial face-to-face meetings. Can I ask you maybe if you had some particular sessions that you found, of course, they are all interesting, but that you participate and they raised your interest, your attention?
Well, first of all, for those who like important trials, whether they are negative or not, we had at least 3 trials on COVID-19, which were published simultaneously in the Lancet or in Nature Medicine, and 2 on new medications, one on a JAK inhibitor with rather positive results, and the other one on anakinra in patients with high SUPA levels, and it's also quite positive. So, we may have 2 new therapeutic interventions. And then there were 2 important studies, one published in Lancet, the other one still submitted to a major journal on respiratory support. Is CPAP better than high flow oxygen? Yes or no? You may argue that it depends on the patient. And then, of course, the meta trial on prone positioning in awake patients that seems to also result in better outcomes. And we have 2 other papers in the JAMA, one on extracorporeal CO2 removal, one on PaO2, optimal PaO2 in respiratory failure. Both studies are negative, but that's something of importance. I think it's more important, as you alluded to, Fabio, to outline the importance of discussions and debates around some elements. And about the COVID-19 therapies, we had a wonderful session on what we have accomplished and what we could have done better. Because, of course, people say we have made great progress in the treatment of COVID-19. Some others claim that we have not made so much progress. And I would personally stand in the middle and acknowledge that by trying to go very fast, and that's important to have therapeutic interventions that could be rapidly available. At the same time, the studies did not collect so much information, and blood sampling was sometimes a bit deficient. And so to understand which patients could benefit the most, it's not always entirely clear. So we had a beautiful discussion about this, and about personalized medicine. Good questions about should we still speak about ARDS. There are several papers published or in press by Gattinoni and Michael Mattei and others saying that after all, labeling ARDS doesn't help very much because there is no specific therapy. ARDS is a syndrome. I have nothing against ARDS as such, but I think it's foolish to try to find a given therapy for ARDS. We need to deconstruct the syndrome and return to basic illnesses and treat a given patient with an appropriate respiratory support and treatment support. Do you agree with that, Fabio?
I fully agree. I was also part of some interesting discussion, for example, on cardiac arrest. We discussed, of course, as you may know, TTM2, which was presented online, but never been presented officially into a meeting. So we had a very nice round table. We have a discussion about TTM. Yep. And we understood basically that there are main changes in the practice all over the world. Then people can also interpret the data according to their own reality. And we also discussed during the meeting the ILCO recommendation, which was a proposal just published the day of the roundtable. And I basically understood that the recommendation as it was totally unclear for the participants. So this opened again the discussion, even when guidelines are there, how to apply this recommendation statement to my patients. And the same, we had a discussion about, coronary angio, because the great German study was just published, or doing or not an early coronarography after cardiac arrest. We also try to understand in which patients the question to do it or not to do it immediately would apply, rather than those where I would immediately go for a coronary angio. And again, translating the results to the study, to the practice, and understanding that not all the patients are those that are included in the studies for whom I have potentially a response. So this was really nice. And the only way, as you mentioned, to do that is to discuss with the faculty, making questions and try to make, even practical example, what should we do in that patient, and clearly understanding that not all the studies give us the response. So it's important to share experience to basically at the bedside take the good decision.
Very good. Yeah, absolutely. And we need to go towards a more personalized approach. I mean, it's ridiculous to, and it was emphasized during the meeting, it's ridiculous to randomize patients for 1 liter of saline or 1 liter of balanced solution and hope to find a difference in mortality. Nobody thinks that there will be any difference in mortality. And you randomize 10,000 patients to show that there is no difference. We had also these discussions about the bundles, the 1 hour bundle in particular. The golden hour in trauma has been abundant in the field of trauma. And why would it be different in sepsis? It could actually slow down the process rather than activate the process. So we should record what we do, and the time delays are important, definitely. But any kind of 1 hour limit doesn't make much sense actually in that field. Okay.
May I ask you, maybe, of course, ISICEM 40 is over, but we already in the view of ISICEM 41, which will be in March 2022. Is there anything that you have done differently? Of course, rather than having more participants and more lectures, of course, this is our aim. Are there any new ideas in the future or there is this tradition of ISICEM as it is, as a symposium that we stand all over, aiming at top speakers and having the more participants to raise the knowledge and raise training and discussion?
Well, meetings must evolve, and one cannot say it has worked until today, so don't change a winning team. No, that's not true. And indeed, you are in a good position to know that when we go to a meeting, it's not just to receive, to attend a conference, a lecture. We can do it on internet indeed, but it's to have this interaction that you emphasize very well. So I think we will have more hands-on sessions, more simulation sessions, more roundtable discussions, more debates. That's the essence of the meeting. And as we all know, we sometimes learn more in the hallway or before a cup of coffee or a glass of beer than in the conference room. So let's admit that meetings have this very important pragmatic aspect, and we need to really maintain and even further develop them.
Okay, so I would say that probably we are working on that, and we will offer an even better ISICEM 41 in a few months to all the people who could, we hope, of course, be in Brussels with us.
And we need to remind people that all suggestions are very welcome, and positive criticism is very, very welcome. Nobody's perfect, and we are certainly far from perfect. We can improve the system substantially.
Okay, so thanks for your thoughts, and I hope that we will have more and more face-to-face meetings to do, as you said, promote knowledge, research, training, networking among all ICU physicians.
Absolutely. Yes.
Bye-bye.
Take care. Bye-bye.